My dear students, the subject in this video is aerosolized therapies in ICU. We will just take a look into the different devices, the common indications, and the safeguards or the measures that we need to adopt while practicing aerosolized therapy in the ICU. Now, what is aerosol therapy? Whenever we deliver medicines or drugs by liquid or powder medications in the form of respirable articles, or particles that is in the diameter of 1 to 5 micron into the lower respiratory tract, they are part of aerosol therapy. Now, they are used primarily for bronchodilation, anti-inflammatory effect, antimicrobial therapy, mucolysis, pulmonary vasodilation. In the ICU, this delivery may be possible in spontaneously breathing patients, in patients on NIV, in patients on invasive mechanical ventilation, as well as in patients who are on ECMO. So now these are the various devices which are used to deliver the aerosols. As you can see, it is the jet nebulizer, which is in the upper corner. Then it is the vibrating mesh nebulizer in the below corner on the left-hand side, the ultrasonic nebulizer here on the right upper corner. And as you can see, it is the multi-dose inhaler with spacer on the right bottom corner. So these are the common devices which are used to deliver drugs in the form of aerosol in the ICU. Now let's go through each one of them and see their advantages and disadvantages. Jet nebulizer, it is the oldest genera of the drugs which was used, of the device which was used to deliver aerosol therapy in the ICU. The mechanism is that because of compressed gas at 6 to 8 liters per minute, which is generated, this creates a negative pressure because of Venturi effect, and it draws liquid medication into aerosol droplets, and those are deposited into the respiratory tract. The implications in the ICU are that it adds extra flow. So this alters the delivered tidal volume and also the FiO2 because it becomes diluted. So this can trigger ventilator alarms. It has got low lung deposition because the particles are heavier of 10 to 15%. So they stay in the nebulizer only. And expiratory limb has a significant drug loss. So these have to be kept in mind whenever jet nebulizers are to be used in the ICU. So their limitations in ICU will be that they require flow source, which may not be there. Performance is variable. There can be condensation in the circuit, which will naturally add up to the resistance, poor efficiency in ARDS, and they have a high propensity to cause environmental contamination. So they get dispersed into the environment much more than the other devices. So these have to be kept in mind while using jet nebulizer. However, they are useful, and in selected situations, they can be used to adopt the aerosolized therapy in the ICU. Second, we come to the next generation of the device, which is the ultrasonic nebulizer. Here, the piezoelectric vibration that generates the aerosols and which are deposited into respiratory tract. So there is high aerosol output. It warms the medication solution because it generates heat, and it is less suitable for suspensions like antibiotics. So although it is suitable for other therapies like bronchodilators and etc., for antibiotics, because they are available in suspensions, it may not be the ideal. The ICU relevance for this device is that it is better output than jet nebulizer, but it is not ideal for protein-based or heat-sensitive drugs because it generates heat which can destroy, and it is also less common now in critical care. It is, of course, more common than jet nebulizer, but still, in comparison to its earlier use, the use has reduced. The major ICU concern are the heat, and this heat may denature the epoprostenol, which is used, certain biologics, which are often used in patients in ICU. The third device is the vibrating mesh nebulizer, which is the gold standard, and almost all ICUs use this vibrating mesh nebulizer, particularly when antibiotics have to be administered. The mechanism is that microporous mesh vibrates and uniform fine particles are aggregated and scattered into the respiratory tract at the perfect location. The advantage is in the ICU that it works in line with the ventilator. It is silent, doesn't make any noise. There is no change or no change is required in the ventilator parameters. It is compatible with non-invasive ventilation, and it proves to be excellent for aerosolized antibiotics, epoprostenol, brochodilators, and hypertonic saline. So it is something which is universal uh, device which can be used. And its placement in the ventilator circuit is important because its best position is in the inspiratory limb, around 15 to 20 centimeter proximal to the Y-piece, and one has to avoid it too close to the humidifier or in the expiratory limb because that will produce wastage. Metered dose inhaler with spacer, it is also used sometimes, not always, but its advantages are that precise dosing, faster delivery, and less contamination is possible. Here you can see that this is the expiratory limb of the circuit. This is the inspiratory limb. Here is the metered dose inhaler, and that there is the space chamber. So this is the inspiratory line. So it requires coordination, and one can use only limited drug types. Also, it is not suitable for antibiotics at large. If we compare the devices, we can see that the jet nebulizer adds gas flow, so it dilutes the FiO2 as well as the flows are increased, so the ventilatory settings get altered. None of the other devices, ultrasonic vibrating mesh or MDI, adds gas flow. The deposition efficiency is high with vibrating mesh, so almost all the particles which are required to be deposited in the lungs, in the in the lower respiratory tract, wherever gets deposited. It is moderate with ultrasonic and MDI, and it is low with jet nebulizer. Circuit integration is excellent in vibrating mesh, moderate in ultrasonic, good with MDI, but poor with jet nebulizer. Best ICU use is in case of vibrating mesh because it has broad ICU use. MDI is useful in acute bronchospasm. Ultrasonic has limited use, and jet is used mainly in basic bronchodilation when patients are preferably not on ventilator. Antibiotics are excellent with vibrating mesh, suboptimal with jet, not ideal for ultrasonic or with MDI. The cost is high with vibrating mesh. It is moderate with ultrasonic, and it's low for both jet and MDI. If we look into the drugs which are delivered in the ICU using these devices, primarily we deliver bronchodilators like salbutamol and ipratropium in indications like COPD, asthma, ventilator bronchospasm, etc. Corticosteroids such as budesonide, also in COPD, asthma, as well as post-extubation stridor. Mucolytics like NAC when patients with thick secretions, when we need to break the disulfide bond and we need to administer drugs for that reason. Antibiotics like colistin, tobramycin in patients with VAB, selected cases, although strong evidence is not there, but still many people use it, and conflicting reports exist that they give good result. Vasodilators like epoprostenol in refractory hypoxemia or in RV failure, this is used. Hypertonic saline 3 to 7% can be used with them in case to cause mucus clearance. For aerosol delivery in mechanically ventilated patients, the particle size has to be 1 to 3 micron to delivered in the alveoli, 3 to 5 micron for bronchus, and more than 5 micron in the upper airway. So in the ventilator settings, one need to know that better deposition or better pharmacokinetics is achieved with low inspiratory flow, longer inspiratory time, no humidification for the time being. Temporarily, the humidifier can be removed. Volume control ventilation with around 20% of end inspiratory pause. The nebulizer position in the circuit, best position is in the inspiratory limb, around 15 to 20 centimeter before the Y-piece, particularly for vibrating mesh nebulizer. We have to remember some special situations like ARDS, where aerosol distribution is heterogeneous, dependent lung is poorly ventilated, and recruitment improves the delivery of the aerosol. ECMO aerosol is still useful, but may reduce the ventilator pressures, so there is no direct interaction with the ECMO per se. With NIV, significant mask risk reduces the deposition of the drugs. Use the vibrating mesh nebulizer inline and avoid open nebulization. In prone patients or patients or prone ventilation following ARDS, delivery is possible, but the deposition is unpredictable. And if it is to be used, the vibrating mesh nebulizer is to be preferred. So if we go by device selection by ICU scenario, if the patient is having bronchospasm on ventilator, we have to go for either MDI or vibrating mesh nebulizer. To deliver aerosolized colistin for VAP, use only vibrating mesh. For refractory hypoxemia, where we deliver inhaled prostacyclin like epoprostenol, we use vibrating mesh nebulizer in continuous mode. In NIV with leak, where there is some amount of leak is inevitable with NIV, we prefer vibrating mesh nebulizer inline. And in resource limited settings in the ICU, of course, there is nothing is better than the jet nebulizer. We have to remember that certain point that vibrating mesh nebulizer produces least environmental contamination. The jet nebulizers increase the aerosol spread. One has to replace the expiratory filters regularly and also avoid open mask nebulization in isolation patients, because then it will spread to the other patients or other people who are there in the room. In aerosolized, antibiotics are particularly useful in MDR VAP as well as adjunct to systemic therapy, although no guidelines recommended their unilateral use or selective use. They can only be used in addition to the standard therapy. Rationale is that they achieve high epithelial lining fluid concentration, which is not possible otherwise by other routes, and it causes lower systemic toxicity since the amount reaching the systemic circulation is much less. The common drugs which are used by this route are colistin, tobramycin, and amikacin, but there are certain risks which include bronchospasm, ventilator filter obstruction, as well as circuit contamination. So the final take-home message on this account remains: device choice matters more than the drug choice in most ICU scenarios. Vibrating mesh nebulizer is preferred in ventilated patients. Always optimize ventilator settings before blaming drug failure, unless it is in the volume control mode with low inspiratory flow, prolonged inspiratory time with 20% inspiratory pause, with temporary removal of the humidifier. Adequate drug delivery is not possible. So we have to optimize the settings before blaming drug failure. Aerosol antibiotics are adjuncts. They are not replacement to the systemic. And deposition of the drugs in its intended site is a function of both the physics of the drug, that is its nature, specific gravity, etc., as well as the physiology, that is the flow, the effect of gravity, the generation, the amount of distribution of the aerosol, etc. So thank you very much.